Dr. Joseph Coselli, and it's an honor to present this to the GenTAC meeting, Aortic Summit. I'm going to discuss surgical cut points and familial aortopathy. These are just some general guidelines. We're going to flush this out and hang a lot of ornaments on the tree. But the point is that over the last several decades, diameter-based guidelines have not only been the basis for these decisions, but they've also fluctuated in their recommendations. So we're going to discuss bicuspid valves, Marfan syndrome, Lowe's Deets a little bit, and then aortopathy in individuals of small stature. The problem with this issue, of course, is the proximal aorta is the area of the aorta which is at most risk in virtually all aortopathies, and that's what we're going to focus on. So what happens? It dilates up, it becomes aneurysmal, then it either ruptures, dissects, and can end the life of a patient prematurely. And when it comes to these diameter-based decisions, size does matter, and we're going to focus on that. In that theme here, from this paper from many years ago by Cody from the database out of the Yale program, they described, and this is for aorta across the board, proximal, arch, thoracoabdominal, descending, etc. But thoracic aorta across the board, when they get to be about 6 centimeters, that's when bad things started happening: death, rupture, dissection, etc. So the idea is don't wait till it gets to be 6 centimeters, carry out surgery at an earlier point, and that would be between 5 centimeters and, well, 5 3/4, but get to it before this inflection point. And yes, in all clinical decisions, particularly when it comes to surgery, we're dealing with a risk-reward analysis. And what we want to be is in the highest possible reward with the least possible risk in our decision-making as much as possible. So what does that mean here? The reward is a longer life, hopefully with a good quality, that in this particular circumstance may require a decision to do a proximal aortic surgical replacement of the aorta. And the risk, of course, would be the balance of the natural history of the disease, and as I mentioned, at 6 centimeters, the increased risk of rupture, dissection, and death. So what's the risk of surgery? So let's just look at this STS database, looking at simple aortic valve replacement, mortality of 2.5%, ascending aorta, 3.4%. It requires replacement of the transverse aortic arch. It gets to be more, about 5.2%. And the standard bental, which is a combination of AVR and ascending as well as root replacement, a mortality rate of about 4.2%. So what's the natural history of the situation? Well, it's not good. This paper from Murdoch shows the mean age of death at about 32 years. And this paper from Gott, New England Journal of Medicine, 675 patients from about 10 different institutions. The mean age of repair was about 34 years, but the survival curves are a marked increase in improvement of the lifespan of these individuals with particularly Marfan syndrome, but connective tissue disorders in general. Our tools for aortic repair from a surgical standpoint are very varied. On the left-hand side is the standard bental composite valve graft replacement, but in specific individuals based on a variety of different issues, don't have time to go into all of them here, but just suffice it to say that our tools with regards to replacement of the ascending aorta and the aortic root are quite a few now, and they can be tailored to the individual. When we look at the recommendations over the last couple of decades or so, and going back even further than that to Cody in 1997, it's varied from 5.5, 6 centimeters down to 4, 4.5, 5, etc. It's gone up and down over the years. So what we have to base our decisions on is a set of guidelines that are provided to us by the sponsorship of important institutions: the American Heart Association, American College of Cardiology, EACTS, which is the European Association, the STS, and on the right-hand side, the American Association for thoracic surgery, and guidelines have been published intermittently dealing with these issues over the last few years. I can go into all those in great detail. There's not enough time, so what we really have to do is get to the bottom line. So let's look at this European guidelines, which were in 2012, 2014, and again in 2017. And they're broken down into valvular guidelines and aortic guidelines. The valvular guidelines basically pinned everything down on 5.5 centimeters in an asymptomatic patient, etc., identified, go ahead and move along with surgery. Now, these are not necessarily all patients with aortopathy of connective tissue disorder, but when you have a dilated aorta, you consider to have aortopathy in general. And if you're at a younger age group, say under 50, it's probably associated with a known or an unknown genetic issue. They also pointed out that you could use a cutoff at 5 centimeters if you have so-called risk factors. Risk factors may be a family history of dissection, a desire to have pregnancy, severe aortic regurgitation, systemic hypertension, and or rapid growth, or a concomitant coarctation. If you're going to undergo a cardiac operation, coronary bypass, aortic valve replacement, which is the usual situation, or a mitral valve repair, and your ascending aorta is 4.5 centimeters or greater, then you should have it replaced at the same time. And when they looked at the valvular discussions, that they remained the same and consistent over the years from 2012 to 2017. And when they looked at their aortic guidelines in 2014, again, they were consistent and remain the same. So let's look at the American guidelines. They haven't been quite as clear. We had a set of guidelines in 2010 and then again in 2014. When we look at the aortic guidelines, they were initially very vague, 4 to 5 centimeters. Class 1 recommendations means it's a solid recommendation. Class 2A, it's a little bit less of a recommendation. If you look at the C on the right-hand side, that's a level of evidence of C, which is primarily expert consensus. These are areas where we don't necessarily have prospective randomized trials. In their valvular section, when they were looking at the aortic valve in particular and specifically, and considered the aortopathy aspects, again, it was almost identical to the European guidelines, 5.5 centimeters, 5 centimeters with risk, and 4.5 if you're undergoing an aortic valve replacement. Because of the difference between these two recommendations, they published a clarification statement in 2016. And again, this is the American Heart and the American College of Cardiology, where they spell things out a little more carefully, and they're almost identical to the European guidelines. So we have some concordance between Europe and the United States. 5 centimeters if there's a risk factor, which is a family history of dissection and or rapid growth. And it's important here to point out that they've included this if you're at low risk for surgery. In other words, it's 5 centimeters is the cutoff if it's done by an experienced surgeon at a center of excellence that has a track record of very, very good results with low mortality and low morbidity for this operation. And again, if you're undergoing an aortic valve replacement, 4.5 centimeters would be the cutoff. To point this out too, the AATS in 2018 came out with a set of guidelines that are almost identical to everything I've already said with regards to the cardiology programs in the US, the European associations, and now the surgical program associated with the AATS. They've thrown in a few additional points with regards to 5.5 centimeters, that those patients with a root phenotype, or again, hypertension, family history of dissection, a family history of sudden death, coarctation, as I mentioned before, or rapid growth, which would be greater than 0.3 centimeters per year, 5 centimeters should be your cutoff. And again, if you're operating on the aortic valve, 4.5 centimeters. And these latter ones have a class 2 recommendation where the 5.5 centimeters is specifically a class 1 recommendation. Now let's shift to Marfan syndrome in particular. Let's look at the European guidelines. Basically, they've already been spelled out, but they have a little lower threshold. We go from 5.5 down to 5 centimeters in their aortic guidelines in 2014. And again, the Europeans have been very consistent with their recommendations. In their valvular guidelines in 2017, they have a cutoff of 5 centimeters. So it's not 5.5 for Marfan syndrome. It's lower. It's 5 centimeters. We've moved to the left. And again, 4.5 centimeters, as I mentioned before, with risk factors and or the need for an aortic valve replacement. The guidelines in the aortic section for the cardiology associations in the U.S. are actually fairly vague, that 4.5 to 5 centimeters. Their valvular guidelines, there's no recommendation or mention of Marfan syndrome. Let's go back to their aortic guidelines. They also include an additional issue which has to do the ratio of the maximal area of the aorta divided by the height, if that's greater than 10. And the idea is that there's some specific patients that are extremely tall or much shorter, and you need some way to kind of adjudicate that so that a 5 centimeter aorta in an extremely large patient may be quite a different issue than somebody who has a 5 centimeter aorta and they're 4.5 feet tall, et cetera. So they built that into their guidelines going back to their aortic section. Let's mention Lowe's Deets syndrome for a few minutes. We do have some information on that, although it's not as specific as some of the others. But it is mentioned in the American Heart Guidelines as well as in the European guidelines. Initially very vague, 4 to 5 centimeters. But in more recent guidelines, it's very interesting. With regards to transesophageal echocardiography, if the internal diameter is 4.2 centimeters or greater, or if you're using the outer diameter of the aortic wall, 4.4 centimeters, so we've moved even to a lower criteria for patient with Lowe's Deets syndrome based on transesophageal echocardiography. In the European guidelines from 2014, they don't give any really specific guidelines for Lowe's Deets, but it is implied with regards to rapid growth, as I mentioned before, and probably in the range of around anything greater than 0.3 centimeters per year. So then let's go to small stature for Turner syndrome and other similar situations. Again, they're not specifically set out like Marfan syndrome, et cetera, but because of their almost ubiquitous small stature, this concept of ratio of maximal aortic diameter divided by a height in meters greater than 10 would qualify. So that gives us a chance to take actually a smaller threshold in patients who are a shorter stature. And the European guidelines do exactly the same thing. Lower thresholds for intervention considered with a body surface area of patients of small stature. And again, they use an indexed aortic diameter, which is basically the diameter of the aorta rather than the aortic area, and use that on divided by a height in meters squared to have, and the number they use for this, if it's centimeters over meters squared, it's 2.75. But the important thing here is this is indexed to smaller stature. So in conclusion, diameter-based threshold repairs are initially based on hinge points from natural history studies. Further study indicates that this hinge point is probably moving to the left, and cutoff points for those familial aortopathy may be lowered, and we need a great deal of flexibility in our clinical decision-making process in patients with heritable disorders. I'd like to thank GenTAC for the opportunity to present this material.